on Osteo Boston. And if you're listening live, we're happy to have you. And thank you for your patience in getting started tonight. And if you're part of our YouTube audience, give us a thumbs up if you like what you see, and consider subscribing. It helps me to and others in our group decide on content for the future. So thanks so much. Tonight, our speaker was unable to be here. And so instead, I'm going to share another video with the group, and it's something I found quite valuable. And it's from Sarah Morgan, who is a researcher and a clinician. She's now a emeritus director of the University of Alabama Osteoporosis Center, and she has an extensive background in medicine and endocrinology, and also in nutrition. So I found this video quite stimulating to watch, and I'm going to share it with you right now. Okay.
Special guest, Dr. Morgan, with a talk on nutritional supplements and osteoporosis. Dr. Morgan is the Emeritus Medical Director of the University of Alabama at Birmingham's Osteoporosis Patient Treatment Clinic and the current director of their bone densitometry service. She has degrees in food and nutrition. Dietetics and food and nutrition and related science, finished medical school and internal medicine residency at the University of Iowa, received a clinical nutrition fellowship and a master's degree in clinical nutrition at the University of Alabama at Birmingham, and she's a professor emeritus of medicine and nutritional sciences in the division of clinical immunology and rheumatology at UAB. Thank you for your time, Dr. Morgan. We are excited to have you here. You can go ahead and get started when you can.
Thank you. I wanted to, I thought I had this set up to show you the ISCD Atlas, but I think maybe in the interest of time, I think maybe we'll just kind of go ahead with my lecture here. All right. So I just tell you, there is a new DEXA Atlas on the ISCD website. It's a member benefit. It's something I have been interested in for a long time. I think we're getting close to 200 cases there now. So I would really recommend that you check this out. We would love for people to submit cases. And you'll see that we have a whole wealth of things about artifacts and positioning and analysis errors. There's also a good place for you to submit cases that are really badly done DEXAs, because I find those very useful in teaching. So I'm from UAB, and we have a multidisciplinary clinic. I think that being a dietitian, I think having a multidisciplinary clinic has always been very important, and osteoporosis, as you all know, is a very multidisciplinary specialty. And so on a day that we have osteoporosis clinic, we have a physical therapist there, we have a patient educator. We haven't been able to have the lunch during COVID, but this is the way that we used to set up our clinic. We do have a website, and we've set up a virtual classroom. This just shows some of the things that we do in the clinic, and this is on our virtual classroom. You can go to this link, and we have some patient education materials, and so we ask our patients to look at these materials before they come to clinic. So I want to talk a little bit about nutrition, and I think being a dietitian all these years, it's really been interesting in all facets of medicine. You know, one time we have a positive study about a nutrient, another time we have a negative study. Lots of times it's, you know, equivocal. And so this is just another example of the Preventive Service Task Force recently released some information related to vitamin and mineral supplements. And so some of the things were positive and some of them were negative. So one of the things I wanted to first talk about is why are nutrition results so confusing? And I'm going to refer to sort of one of my heroes in the field is Bob Haney, who did a lot of this work. But basically, the bottom line is that the use of evidence-based medicine and reliance upon randomized controlled trials probably doesn't make as much sense when we're looking at nutrition and any type of chronic disease, for example, bone. And some of the reasons are that for a nutrient to have an effect, it really has the best effect when you're treating a person that has inadequate nutritional status. When you're doing a drug study, you're not doing something that's caused by the absence of a drug. So, and a lot of the effects of nutrients are sort of within the noise of biological variability. So it can be very difficult, very challenging to study a nutrient and a chronic disease. This is a very important slide. It talks about how nutrient effects occur. They really occur as a sigmoid curve. So when you're deficient down at the bottom, you may take a lot of a nutrient to be able to have an effect. In the middle, you have an effect, but it's very important to look at C. This is when an individual is sufficient. And so if you have a person that is sufficient in a nutrient and you're doing a clinical trial and giving them the nutrient, you're really not going to see much of an effect. The effect that you might see is toxicity. So that's one of the things that we need to know about nutrients studies is what was the nutritional status of a patient when we started the clinical trial. And so he talks about the fact, once again, that a randomized controlled trial is probably not best suited for nutrition studies. Nutrient effects are polyvalent, and nutrients affect, many tissues in the body, and we have interactions between nutrients. So calcium and vitamin D is the one we think about a lot, but there's certainly some interesting data about protein intakes needing to be adequate for calcium to have an impact. So all these things need to be taken into account, and oftentimes they're not taken into account. So once again, another reason that some of these studies are a little bit equivocal. Another issue is that different tissues can have different response curves. So depending on where you're measuring, it may be shifted to the left or to the right. Another important thing about nutrients is the vista on which you do the clinical trial. Nutrient effects may take decades to be manifest. When we talk about nutrients, sometimes we talk about, for example, lifetime intake of a nutrient like calcium. So when we're doing a clinical trial with a drug, it can be a relatively short trial. But doing a relatively short trial, 6 months or a year, may not be adequate to find an effect of a nutrient. So this just talks about this fact. What Bob Haney talks about is he talks about latency. So, with calcium, oxalate urolithiasis, this has a short latency. But something like osteoporosis has a long latency. With vitamin K, clotting disorders have a short latency, but perhaps osteoporosis and looking at vitamin K, maybe we need longer clinical trials if we're going to see any type of an effect. So one of the things that we certainly see in the literature is the wonderful meta-analysis. So everybody seems to take a meta-analysis part, but what Bob Haney says about this, and until we link outcomes to blood levels achieved and understand what analytic to measure, meta-analyses will not answer how much is enough. And so I would just tell you, when you're looking at, a meta-analysis related to nutritional status, think about some of these things. Did they know baseline nutritional status? How long was it? And so there's many reasons when you look at a meta-analysis that things can be equivocal. This is my opinion, for what it's worth, is that I think in many areas of medicine, we started out in the, the glory days of nutrition. We started out with, nutrient deficiencies, and we were able to look at, nutrient deficiencies. But now I think that the pattern is evolving in nutritional studies, and probably rightly so, to look more at dietary patterns. After all, that's what we do. We don't eat a single nutrient. We do eat single nutrients, but we eat it in the context of diets. And so I think we'll be seeing a lot more related to dietary patterns and all sorts of medical disorders. It kind of brings us, I think, to this wonderful article in the New England Journal of Medicine, the VITAL study. And, this has gotten a lot of play, where they talk about the fact that it did not result in significantly lower risk of fractures. Once again, this was among a healthy population. They did do some analysis based upon the initial vitamin D level. I think this was underpowered, but their take on this was that even in a deficient population, that vitamin D didn't do anything related to the fracture. And I'm sure many of you have read this editorial that was in the New England Journal of Medicine. And so once again, pretty definitive that we should stop screening for vitamin D levels or recommending vitamin D supplements in the healthy population. What I would say is that I think you can go back and take some of the lessons of Bob Haney when you look at the VITAL study. A large majority of the patients in the VITAL study had a very adequate 25-hydroxyvitamin D level. So would a response be expected? No. Once again, the follow-up vitamin D level was at 2 years. The fracture data was over a longer period of time, so sort of a temporal inconsistency. I'm not sure that they probably were able to evaluate, things like protein intake and calcium and all those things related to vitamin D. I mentioned to you that there was a subgroup with a low vitamin D level. Once again, I think it was 2000 IUs. Was the dosing adequate? We all know that when we have somebody that's very vitamin D deficient, we may need to use a fairly large dose. And I would say that segment was grossly underpowered. The other thing I would just ask you to think about is it really reasonable to expect a nutrient alone to have an effect on something like bone mineral density or fracture? We know that the effects are sometimes within the noise of biological variation. And so to me, it's kind of like throwing the baby out with the bathwater. Even if I was able to, do a good study and, vitamin D, for example, didn't lower fracture risk, I don't think I would conclude that vitamin D is not important in bone health. So in the last minutes remaining, I want to go on to a little bit about some of the nutrients and the supplements and things that we use in treating metabolic bone disease. The first I'll talk about is slow release calcium. And I'm sure a lot of my patients, take this in, and this is just it's a Citracal product. I have spent a lot of time calling Bayer and asking them for specific data about it. Absorption studies to support or refute the usefulness of the product. I've done this probably over about a 7 to 10 year period, and I have, even though they promised me they're going to send things, I've never received anything. So I generally tell people that no more than 500 to 600 milligrams of calcium is absorbed at a time. And just because I don't have a lot of data, I have tended to shy away from this product. Now, once again, I was able to talk to Bob Haney about this thing. And I'll just tell you what he said. He said he had been contacted several times about a so-called delayed release approach to calcium supplementation. He said, it's my understanding that what one wanted was not delayed release in the sense that this term is usually used in medicine, but instead you'd want gastric retention. And he said that they showed it makes a huge difference in absorbability by the simple device of giving small doses repeatedly over a 7 to 8 hour period. So this is of course literally slowed gastric release and not really what a lot of us think about in the intestine of being delayed release. So I don't really know what the product does, but I kind of doubt that it does anything to gastric retention. So when I talked to Bob about this many times, he didn't have any data, and until they can give me some data, I'm very interested to know how they're saying that it's a delayed release product. Another product that was out there for a long time was calcium plus genistein. And the impetus for this occurring was that there is something called a medical food that's called Fostium, which contains genistein. Now, this is a paper that I wrote about medical foods. Medical foods are sort of halfway between dietary supplements and drugs. And there is the medical food. There's all sorts of regulations about medical foods. You use it to sort of treat the dietary, the metabolic effects related to a chronic disease. And so because there is the medical food Fostium, and there is data from Italy that it was done in an osteopenic population that it can increase bone mineral density, well, the manufacturer said, well, let's add genistein to Citracal. And this is going to be, pretty much similar to the medical food, the Fostium. Well, actually, just to make a very long story short, manufacturers of Fostium, and they were involved in the study, actually did a clinical trial between the Fostium and the Citracal plus the genistein. And so they had the medical food, and then they had the over-the-counter supplement. You can sort of see what was in it. It has the same amount of the genistein, which is a phytoestrogen. It does have some calcium in it. But the bottom line here is that the genistein from the supplement, from the over-the-counter, had a lower overall uptake than the Fostium. And if you read the paper, they talk about the effect that probably the calcium that they use and other things in the formulation are going to affect the pharmacokinetics. So what that says to me is that if you're going to use a medical food, you need to know about it, and you can't always conclude that just putting something like genistein in a supplement is going to do the same as the medical food. So a medical food is based upon established science, and there's no requirement for this for a dietary supplement. So you can't always conclude that the dietary supplement has a similar effect as a medical food. So if you're going to use some of these types of preparations, it's important to ask questions to know that they actually do the same thing. I'll finish off here with Algical and strontium supplements. Of course, strontium is in the same column of periodic elements under calcium, so it's heavier than calcium. And the whole reason that people started wanting to put strontium once again in calcium supplements was because of the strontium renolate and that the usefulness. Now, of course, this is no longer used in Europe, but still that doesn't stop people here in the United States from wanting to put strontium in calcium supplements. You remember from this very nice paper that because strontium is heavier, what it's going to do is going to have a physical effect. It's going to be incorporated into hydroxyapatite, and it's going to increase bone mineral density just because it's heavier than calcium. So there's all of these products. I've gone round and round over the years with the Algical people, asking them questions about it. They keep on sending me all of these old papers from 2007, and but I think you all know, and you have these patients. I mean, I have patients that swear by this. And generally, because of the strontium, they'll improve bone mineral density, but I can't tell them that they're having any fracture reduction. And, just look at the website. I mean, they have some really interesting statements that they make about some of these supplements that contain, strontium. Most calcium supplements can increase bone mineral density. This one does. And so these are just the papers that they will talk about the effectiveness of the calcium with the strontium. this was an open label study, and you can see that there were 3 different plans: Plan 1, Plan 2, Plan 3. Plan 3 was the supplement that actually did not contain the strontium. But I found interesting here in the clinical trial that the largest increases in bone mineral density occurred in Plan 3 rather than Plan 1 or Plan 2. So this is counterintuitive to me, because the strontium is going to be incorporated, and that should be increased bone mineral density. So this doesn't really, to me, support the usefulness. There are a couple of other studies that have been done. This is one that they talk about. It was a 7-year longitudinal trial, and once again, they added strontium. And what they did is the red line here, this was their trend of their annual increase in bone mineral density, and then they used an age-matched control group. They didn't really have a control group, and their conclusion was that, of course, the group that used the strontium went up, whereas the age-matched control group went down. So, they concluded that the strontium supplement in and of itself was obviously much better, than doing nothing. This was something called the COMB trial. It was done in individuals who declined or failed drug therapy. And once again, the clinical protocol added strontium. And once again, they did some kind of interesting things here. They looked at the increases at the femoral neck, the total hip, the total spine. They compared it to strontium renolate, they compared it to alendronate, and they compared it to risedronate. I mean, these were different trials, and so I don't think that these are reasonable, reasonable comparisons. But once again, when you just look at the numbers, it makes it look like, wow, this strontium supplement is much better than alendronate or risedronate at 1 year. So there were a lot of limitations that I found to these, clinical trials. So once again, strontium by its physical effect can increase bone mineral density, but I don't think we know anything about fracture reduction. I can tell you that they will never do fracture reduction trials with a nutrition supplement. So my bottom line on these is that there's no long-term studies related to efficacy safety. It confounds the DEXA, and generally there can be side effects. I've had patients with side effects on these supplements, so I generally tend to dissuade my patients from using these, though over the years I certainly have had some people that swear by these things, and I've just tended to follow them. So with that, I hope I stayed on track, and I'd be happy to answer some questions.
Rowan, this is Joe. Can I ask a question?
Please.
So that was great, Sarah. I really appreciate it. So I a question about the strontium, and then another question. Because of the European stuff with the cardiovascular safety, I have been telling my patients that they shouldn't take it, that I'm concerned about its danger in absence of any efficacy data on strontium citrate. So that's just, I'll ask you to comment on that. The other question is, how about K2?
So I totally agree with you. Like I said, there have been no long-term studies. I don't know to what extent the AlgaCal people, look at that. I mean, that's a real problem with a nutritional supplement, but I'm not sure I've seen anything reported. It is a different salt citrate, and if you go into the AlgaCal stuff, they make a lot about the fact they're using citrate instead of the renolate. So, but I totally agree with you, and I think there's many reasons that I tend to not recommend it to my patients. What about K2? Well, I think we should ask Neil, but there have been no clinical trials yet which have definitively shown anything related to bone mineral density or fracture reduction. Once again, I guess once again I would ask the question. I mean, maybe it's going to be difficult to show that noise within the biological variability, and maybe we need a much longer clinical trial. The other thing, when I think about vitamin K, we all make vitamin K in our colon, and it probably reflexes back up through the ileocecal valve into the small bowel. So, you know, how many of us are truly vitamin K deficient? I mean, you know, if we're on Coumadin or if we're on broad spectrum antibiotics, then yes. But you know, perhaps it's going to be very tough to show that.
All right, we have a question from El Fitton. Why did they stop using strontium in Europe?
It was cardiovascular, myocardial infarction and cardiovascular problems.
And is that something you tell your patients, Dr. Morgan?
About the fact that strontium is no longer used in Europe?
Yeah.
Sure, yeah. And, you know, I mean, even when they talked about it in Europe, it was pretty clear that they weren't going to do any clinical trials in the United States. So.
All right, any other questions for Dr. Morgan? Well, thank you, Dr. Morgan. Very informative, very helpful, and very relevant to practically every patient that we see.
Okay. Let me just hold on a second.
Yes.
All right. Hello, everyone. I just want to, before we stop the recording, I just want to say we will take a minute and discuss these things with the Osteo Boston group, but thank you for getting on, and be sure to give us a thumbs up or subscribe to our channel. Thanks for listening.